Hi, this is Janet Braun. Welcome to Competency 8 about bleeding problems in pregnancy. Bleeding is always abnormal in pregnancy. The blood loss may be visible or it may be concealed, and excessive blood loss leads to hypovolemic shock. Here is a review of the signs and symptoms of hypovolemic shock, which you have recently studied. In the first trimester of pregnancy, the most common cause of bleeding is spontaneous abortion or miscarriage. This is a fairly common event in that 15 to 20% of known pregnancies result in miscarriage and up to 50% of all pregnancies, so that many of them occur before the woman even knows that she's pregnant. What you see listed, the different types of spontaneous abortion and their description. The threatened AB or vaginal spotting early in pregnancy sometimes does result in a successful pregnancy. Missed AB is the fetus is actually expired and the woman requires a D&C to remove the products of conception. In the complete AB, those products are expelled spontaneously. In the incomplete, she also needs a D&C. The hydatid mole is an abnormal formation of the pregnancy where the fetus dies early and the uterus becomes filled with this mass of abnormal grape-like cells. The symptoms show up as pregnancy-induced hypertension or abnormal symptoms and no fetal heart tones in the first half of pregnancy. As soon as that's recognized, an ultrasound is done and the diagnosis is made. Treatment requires a D&C to remove this abnormal growth. There's a risk of cancer following hydatid mole, and so the serum HCG levels are followed by the lab until they go all the way down to 0 or at least 12 months. The treatment may include methotrexate to be sure that all of the cells of this abnormal growth are gone. And contraception is important for at least 12 months, so that's an important place for nursing education for the woman. Complications of spontaneous AB include hemorrhage, infection, and isoimmunization of the Rh-negative woman. In the first trimester, a common cause of bleeding is ectopic pregnancy or implantation of a pregnancy outside of the uterus. This usually occurs in a fallopian tube. The woman usually doesn't have any symptoms until after she misses her first period, and then she may begin to feel sharp, low abdominal pain. She may or may not have bleeding, and there can be acute internal hemorrhage going on. So treatment for ectopic pregnancy, if the pregnancy is early and it is unruptured, can be medical by using methotrexate or mifepristone, which cause the woman's body to dissolve and expel the pregnancy. If the ectopic pregnancy becomes ruptured, this is an emergency situation requiring immediate surgery. Laparoscopic removal of the pregnancy is done, and she may lose the fallopian tube in the process, which affects her future fertility. After ectopic pregnancy, the serum HCG level is followed by lab again until it goes all the way down to 0, and RhoGAM is indicated for all Rh-negative women. In the second trimester, placenta previa is a cause of bleeding. This is a low implantation of the pregnancy and the placenta on the lower uterine segment. You see a picture here of various locations of implantation of the placenta, and risk factors for placenta previa are listed at the bottom. The low-lying placenta previa or marginal placenta previa sometimes can migrate up the wall of the uterus as the pregnancy grows. If that occurs, the woman may be able to have a successful vaginal delivery as long as the placenta is not covering the cervical os. Placenta previa is either detected on ultrasound or more often by sudden, painless, bright red bleeding early in pregnancy. Nursing history is important. We need to do an accurate estimation of the blood loss that the woman has had and the other factors that you see here. So if she has clothing or pads that she's been using that are saturated with blood, we ask her to bring those things in so that we can make an estimation of the blood loss. She'll be placed on limited activity or bed rest for the remainder of her pregnancy and be followed by ultrasound. Most importantly, no vaginal exams are done for the woman with placenta previa, as that can cause bleeding. Delivery is attempted at around 37 weeks as long as the baby is showing a mature LS ratio, meaning lung maturity. So she may have a vaginal delivery attempted. If her placenta has migrated upward, there can be potential bleeding during labor or fetal distress. Cesarean birth may be necessary if the cervical os is covered by the placenta. In the third trimester of pregnancy, placental abruption is one of the most common causes of bleeding, and this is a premature separation of the placenta from the wall of the uterus. Signs include bleeding that could be visible or it may be concealed. The woman most likely develops severe abdominal pain, and her abdomen becomes distended and hard like a board. The fetus will be in distress if the baby is not getting sufficient oxygen and nutrients. So treatment for placental abruption is IV fluids, type and cross-match for possible blood transfusion, and delivery. So if she's in labor and close to vaginal delivery, that may be able to be successful. Most often cesarean delivery is necessary. So the nurse will prepare the mother for her delivery. Monitor the fetus and the mother. Risk factors for placental abruption are listed on this slide. Another cause of third trimester bleeding is DIC, disseminated intravascular coagulation. This is a life-threatening blood clotting disorder that results most often from hemorrhage in pregnancy. Abruption hemorrhage or postpartum hemorrhage. Other causes of DIC include sepsis, trauma, retained fetal demise, or amniotic fluid embolism, which gets into the mother's blood. So after a hemorrhage, there's a high level of coagulation taking place at that location of the hemorrhage. And so the platelets and fibrin in her blood become tied up and busy. There then are not enough of them left. They become depleted. So the result is either severe clotting or bleeding defect throughout the rest of the system. We might see symptoms of petechiae or severe bleeding from the vagina or from other body orifices. The labs that are important are PT-INR, fibrinogen, D-dimer may be elevated in DIC, the CBC, and especially the platelet count being critical there, type and cross-match. Treatment includes stopping the original hemorrhage or the cause of the DIC, administering blood or blood products, and sometimes heparin is used to release the clotting factors that are tied up. Thank you for listening to Bleeding Problems in Pregnancy.